once they're not having pain walking and they can tolerate moderate levels of resistance without any pain, I'll let them start to do very short stride jogging in the clinic. But as far as sprinting goes, like truly maximum effort sprinting, they have to have their strength has to be at least 90% of the other side, assuming you have some sort of an objective strength measure.
Rehabbers, thank you for joining us. This is your host, Dr. Dillon Caswell. Today, we have an incredible guest on the show, Dr. Dan Lorenz, who packs this episode full of wisdom on the topic of returning to sprinting after a lower extremity injury. It's a great episode. Hope you enjoy. Today's show is sponsored by the Prehab app. This is not just an app, but a solution. You have the opportunity to take control of your rehab, prehab, fitness, and performance needs, all from the palm of your hand. The app is available for download on the App Store for both Apple and Android users. Also, a free 7-day trial is available. Don't wait. Start taking control of your movement health today. Welcome back to the show. I want to start today off with some barbecue statistics. 7 out of 10 adults in the U.S. own a grill or a roaster. 88% of U.S. barbecue consumers say that they usually grill meat, particularly steaks. A1 is currently the most used brand, preferred by over 89.47 million Americans, but this was in 2020. Maybe a new sauce is on the market, but A1 tends to be the favorite one. Why are we talking about barbecue? Well, our guest today is joining us from Kansas. Now, I don't want to upset anyone listening, but I've had barbecue from the Southeast. I've had barbecue from Texas. I've had barbecue from Kansas City. And my vote for the best barbecue has to go to Kansas City. And if you listen to our show for a while, you might be saying, well, your vote is biased because you are a Kansas City Chiefs fan. And that would be true. But in any case, today's show is not about barbecue, although we can dive into it a bit more if our guests would like to. But our show is all about returning to sprinting. And we have an expert joining us on that topic. Today's guest is a doctor of physical therapy, Dan Lorenz. He's the director of sports medicine at Lawrence Memorial Hospital /OrthoKS in Lawrence, Kansas. In 1997, he was an athletic training intern for the Chicago White Sox and an assistant athletic trainer and the physical therapist for the Kansas City Chiefs from 2005 to 2007. He was the founder and chair of the Sports Performance Enhancement Special Interest Group for the American Academy of Sports Physical Therapy for 6 years. Dr. Lorenz has been published several times in peer-reviewed journals and has been invited as a speaker numerous times at local, state, and national conferences in sports medicine. In 2018, Dan was recognized by the NSCA as the Sports Medicine / Rehab Professional of the Year. And in 2014, he was awarded the Distinguished Physical Therapy Alumni Award from Grand Valley State University. I don't know how many more great things we can say about this guy. Dan, thank you so much for joining us today.
Wow, that's quite the intro. Maybe my humility won't allow me to agree with all that stuff, but very, very kind for the invitation, and thank you for having me.
Absolutely. So I think the most appropriate place to start is, where do you weigh in on the barbecue debate? Are you putting up the vote for Kansas, for the Southeast, like North Carolina barbecue or Texas barbecue, or prefer to not vote?
No, I'll tell you what, I've had it all over the country too. And really, I think it's just kind of what your taste comes down to. I mean, I worked in Carolina, which is very vinegary. I've been to Memphis, which is a little more mustardy. It's kind of what your taste is. But I have to say, having been here for about 17 years and being at one point an official barbecue judge, I would say far and away that Kansas City takes the cake. But I know our friends in Texas are going to have they may have shut the podcast off already just by me saying that. So no, but certainly other regions definitely bring their best A game when it comes to barbecue.
Yeah, absolutely. So I think one thing that a lot of people don't know, aside from barbecue, is that when we look at professional sports and we look at professional baseball and professional football, both sports that you have a lot of experience in, that there's at least one similarity between these two groups. And that is that one of the most common injuries is a strained hamstring because of the sprinting demands. For example, in baseball, you can go an inning, I'm not doing a lot of movement, and then all of a sudden you hit the ball and you're sprinting to first or to second. And then in football, it makes sense. There's a lot of different agility. You're moving, there's sprint, rest. So we end up seeing that one of the most common injuries is a strained hamstring. Once that strain happens, the question then becomes almost immediately of, when can I return? And to return to that sport, you need to be able to sprint again, amongst doing a lot of other things, but sprinting it's pretty crucial for those sports. And it's a question that we get all the time. How do I know when I'm ready to return to sprinting? So let's start there with that type of scenario. So Dan, we have a person that they strained their hamstring. They're starting to feel like they're ready to return back to sprinting. So subjectively, they're saying, I feel ready to do this. What objective measurements or what type of assessments are you using to then honor that subjective or that subjective comment of I'm ready to sprint? Here's the data showing that you are ready to sprint. What does that look like? Or what's the criteria to say, okay, let's start with phase one of return to sprint?
That's a complex question because and not to be evasive, but there's lots involved in that. Like, are we in season? Are we out of season? What level of sport are we here? Like, is this Super Bowl in a week, or is this freshman boys basketball? You know what I mean? So we probably have to start with that just to get that out of the way. But all that being said, a lot of times, as you know, when we have athletes in front of us that oftentimes feel that they're ready, oftentimes they truly aren't. So I'll start with very basic things. Are they still tender? Are they still bruised? Are they even walking correctly? If they're not even walking normally, that's a problem. There typically has to be a requisite level of strength before they really would start sprinting. Now, again, running and jogging is much different. I'll certainly let people, even really short stride, in the clinic over, 20, 30-yard distances, almost like a trot. Once they're not having pain walking and they can tolerate moderate levels of resistance without any pain, I'll let them start to do very short stride jogging in the clinic. But as far as sprinting goes, like truly maximum effort sprinting, they have to have their strength has to be at least 90% of the other side, assuming you have some sort of an objective strength measure. There are some provocative tests that you could do in the clinic to see if, that quick stretch is irritable. One of them is the Askling, or the H test is one. You could do what they call an eccentric length and state contraction, where I think probably the best way to explain this verbally is just that you're trying to push the other way and the athlete's pushing back into you as the hamstring lengthens. And is that painful? Typically, if those things are irritable in a very controlled environment on a table, if you start to add speed, they're going to be even more irritable in that context. So I think in a very quick summary of what some things that I would look at, I think that's where I would start.
Yeah, that's a beautiful answer. And I don't think you danced around it. I think the context does matter in these situations, because ultimately what we're trying to do is figure out what is their threshold. And subjectively, their threshold, especially with an athlete, it's probably going to be different than what their threshold truly is for that type of movement. So many times we see athletes that they say, I'm ready. But as you're saying, well, if you can't walk without a limp, then we're not going to be adding speed to that. So we're kind of trying to figure out what is your threshold to this activity. And we're going to use graded exposure to the forces that are being put into that injured muscle to then evaluate to say, you know what, we're not going to sprint yet. We're going to do strength. And this is why we're doing strength. All right, you tolerated strength. You're showing good strength. Maybe you're not ready for a full sprint. So maybe we use the segue of plyometrics to start building up some more speed with these types of contractions. So it all comes down to threshold. And as you're saying, it matters at what point in the season it is, because if the Super Bowl is around the corner, that threshold, that's going to move a little bit quicker because of how dedicated that athlete wants to get back to it. And you might be more willing to take that risk knowing that there's an off season coming up. If it's in the beginning of the season, a little bit different. You might be a little bit more apprehensive because you don't want this athlete to be out longer than what's expected by pushing down too soon. So that being said, let's say we go through these threshold assessments and the athlete passes them all and they're looking good. They're getting ready to actually start sprinting. So maybe they've been doing the light strut around the clinic. Maybe they're starting to jog. What is this first phase of returning to sprinting look like?
So I published a paper a couple of years ago, and it was really in mind for the athlete that's coming more of a post-operative standpoint, like an ACL reconstruction, a meniscus repair, MPFL reconstruction, things along those lines.
Gotcha.
If you're having a pure hamstring strain, going through the program that I referenced, or that we devised in that paper, you're probably not going to need to go through all of that necessarily. That said, if we are talking about a hamstring injury, I would typically start with very short bursts, like accelerations out of the gate, so to speak. So we're talking 10, 20-yard max, because the height of the heel is much lower in those initial phases that they are when you're in the max effort, top speed sprint mechanics. So you're not going to get as much of the hamstring strain in those initial 10, maximum of 20 yards that you would if you were truly getting out past 20 at max velocity, if that makes sense. So just because the hamstrings aren't going to be stretched as much in those early phases of a sprint, that's where we'll start. Does that make sense?
Yeah, absolutely. And from that, there's a lot of important points there, because I know when I started working in the field, we were talking before the recording, but anytime I see a paper that says Dan Lorenz as an author on it, it's a must-read article, and I stand by that statement. I go back to one of your previous articles of implementing strength and conditioning principles into physical therapy, and I remember reading that article and just being like, yes, this is a way to do it, and it's so pragmatic, and it gives you a takeaway that you can use and start using that. But it's important to know why this protocol was made. So as you said, that protocol, that reference paper, that one was made for thinking of people more post-op. If you have someone that has had a hamstring injury, the return to sprinting may look a little bit different, but you can still pull from this protocol and learn, well, how did Dan and his colleagues create this? What did they have in mind? What were the fundamental principles that they used in creating this? One thing that I'll point out from that protocol that I think was really interesting is that in those early phases, the sprints are untimed. We're not getting a stopwatch out and timing the athlete going, where in the later phases, we may be timing it. What was the motivation behind not timing it in these early phases?
Keep in mind, in those early phases, they really aren't sprinting. We talked about in the first phase, it's really 50% effort, so it's like a jog. And largely the reason why we did untimed in the beginning is because we found this program evolved probably over 10 to 12 years. We were very much tinkering, giving it to people. They'd come back, because a lot of times, as you know, in later stage therapy, or rehab, we run out of visits, patients out of money, those kind of things. So oftentimes athletes are working on their own. So you got to give them some structure. And that's really what the genesis of this was, is giving some structure to people. But nevertheless, when we start this program, oftentimes they haven't done a lot of cardio leading up to it. So they're really out of shape. So we originally did this with specific work rest ratios, with the idea being of repeated jogs with specific work rest ratios to build up their overall conditioning and work capacity. But what we were finding was they were just too out of shape. So we did the untimed for the first two steps because we wanted them to get the reps in, but let them have more of a subjective rest rather than a specific work rest ratio. But they had to eventually do those same runs with in the specific time frame. So hopefully that makes sense in how we approached it. And really that's how it went for the following two steps as well. So, I think it's really important too, we talk about this article, because I've had some questions, I don't want to say pushback, but certainly some questions are raising an eyebrow from the strength and conditioning community if this is truly a sprinting program because of the volume. And I say, remember, this is a return to sprinting program. If we were really working on sprinting, we would cut the reps significantly. We would have, maximum recovery, maybe 5-10 minutes between a single rep. So this was the idea of this, is getting people back in shape. Do you have a wide receiver that can run several routes in a row at full speed, jog back to the huddle, rest their 35 to 45 seconds and do it again? That's kind of who we're catering to with this particular program.
Yeah, that makes complete sense. And I think what I thought in my mind when I saw that it was untimed is, one of my buddies, he works with the Buffalo Bills, and one of the tests that they use, I won't say what they're using, but one test that they use, they actually had to change it because of how hard the athletes would complete the test, in the sense that they would never get a clean rep because they were so competitive that they just kept failing the test. And a lot of times with athletes, when you get out a stopwatch, that's like game time for them. They're like, oh, okay, sure, you're timing me, so that means I'm going to go as fast as I possibly can. When we're just like, no, maybe we just want to get a time on it. So maybe as a provider, you're getting some quote unquote hidden times, but you're not doing it for a time with the athlete. Because as Dan's saying, is that this is a return to sprinting protocol, which means that we're further building capacity. We're moving along that force velocity curve. We're building up capacity for the athlete to be able to do all the things that is going to allow them to be successful. And that's not just sprinting in the game. That's running back to the huddle. That's running off to the sidelines. That's running a play in and out. It's multiple times. It's running, and then having a longer rest break at halftime and coming out and having to run again. So it's our duty as rehab professionals and bridging with strength and conditioning coaches to really bridge that gap and make sure that they do have the capacity that's needed for that sport. So another question I have with that return to sprinting protocol is, are we talking just flat surfaces, or are hills getting involved, or inclines or declines, or any other type of sprinting, I guess, accessories that are being used with this? Or is this just straight line, we're going this distance at this intensity with this work to rest ratio?
Well, good question, first off. But then my question back to you would be, what's the goal? Because if we're going to work on going up hills, which is valid, you're going to definitely be working on those back leg, or, the backside mechanics, and working on that stride length, because, trying to get uphill and really getting that punch into the ground, right? So that's the uphill piece. So if that's the goal, then that's what we're working on. Mm-hmm. Can you use this program and adopt it for cutting and change the direction? Absolutely. If you want to if one of the runs is 50 yards, you want to put 3 or 4 cones up and work on whatever intensity it is at that distance. Absolutely. Of course, like, all this comes down to who's in front of you, what's the timing of the injury, what's the contextual factors around the athlete. Is this a repeat injury? Is there any irritability of the joint? All those kind of things matter into it. And I promise I'm not trying to be evasive with this stuff, but it's complex, as you well know. I mean, none of this is ever cut and dry. So, to answer downhill, well, maybe is your goal to work on, eccentric quad control running downhill. If that's a goal, which is a very reasonable goal, then yes, you could certainly do that. But I would obviously, with that, limit the reps, because the level of delayed onset muscle soreness would be much higher. You do these many reps in a downhill context.
Yeah, absolutely. No, and beautiful answer. Again, that what matters behind this is the rationale. So if you're going to add in a hill, what's the rationale of the hill? And if the rationale is that you saw it on Instagram or you saw it on SportsCenter and it looked cool and that's why you're doing it, that's pretty poor rationale. But if you have this rationale of, well, I want some eccentric overload going downhill, or I want to work on these backside mechanics going uphill, or I want to start adding in agility because it's more specific to their sport and the athlete's ready for that, well, that's a really, really great answer. And the context around it all matters. The rationale around it all matters. So that's super important. And I think from this, what we're learning is why Dr. Dan Lorenz is so great at what he does. That these answers are not just this cut and dry answer. It's, I need more factors around it. I need to know, like, what are this person's goal, and then whatever that goal is, we can start tailoring the program to that person. So the next question I have is that people might look at this return to sprinting protocol and they may say, well, we're in this phase. This is our focus. So we're going to go through stage 1, 2, 3, and that's what we're focusing on. I'd like to pick your brain a little bit on what else is happening during this phase. Is the person still working on strength? Are they still working on plyometrics? Or are they just focused on this sprinting protocol? Or return to sprinting protocol, I should say.
This, of course, is going to depend on what their metrics are showing us. But typically my structure that I like to use, and I have to give credit to one of my mentors, Rob Penarello, for really kind of help. I was doing it, but I didn't put it in the ways, I guess, that this, that he referenced it. But, he laid out Al Vermeil's hierarchy of athletic development. He lays it out so nicely. Al Vermeil was a strength coach with the San Francisco 49ers and the Chicago Bulls. I don't even know how many rings the guy has, probably over 10. Well, no, really. But the foundation of athletic performance is strength. And that's really, after you go through mobility and testing and determine where an athlete is, strength is the foundation. So if you're in the next phase would be power, but if you're not strong, you can't be powerful. And then after that, if it's elastic strength. So that's hitting the ground and get it off it quickly. But if you're not powerful, you can't be elastic, and then you can't be fast if you're not elastic. So I guess if there is a strength deficit, you're ultimately not going to be able to reach what is really your ceiling if you still have a deficit in strength. Now, that doesn't mean you necessarily have to squat 600 pounds, but it does mean that you have to have the requisite level of strength, at least be equal to the other side at a minimum. But the other side might not be a great reference standard either. So we try and maximize strength, and then once you've done that, then we try and maximize power. Many different ways to measure that. And then the elasticity piece comes in. So hitting the ground quickly and getting it off quickly. Pete Wayand in his strength or sprinting work in the early 90s, he talked about that the greatest athletes do two things better than anybody else. They put the most amount of force into the ground, which is the strength piece, and then they do it very quickly. They spend the least amount of time on the ground as possible. That's where the power and the elastic piece comes in. So in my view, I always especially try and tell young clinicians and even young, up and coming strength coaches and stuff. I'm a simple guy. Anybody that knows me, I am very much a simple guy because my programs are painfully boring because we try and do things that are too cute. And that's really what it comes down to. Every intervention you're doing, either in the weight room or the rehab setting, should be, am I putting more force into the ground with this, or am I spending less time on the ground when I do it? And if you can answer yes to either of those questions, I think you're on the right track.
Yeah, Dan, I remember sitting in on one of your many presentations, and I remember you saying at the end of it this is why I don't have an Instagram, because everyone would be so bored with what I post because I'm doing the simplest things.
Yeah, we push, we pull, we hinge, we squat. I do all the exercises that are super boring that have been done forever. And yes, I do tubing external rotation for my throwers and sideline external rotation and scaption raises. And, I do always joke that if I had an Instagram, I would just trap bar deadlift every day and just add 10 pounds, so, I mean, it's true, man. I've said this before on other podcasts, and I don't mean to rehash old comments or old jokes, but it really is. It's true. That's why I don't know. I just, my programming is, I feel like I dose well, I load well, and we keep it simple.
Absolutely. And what I've learned so far in my experience is that the greats in the field are the ones that are doing the fundamentals extremely well. They've really learned the fundamentals of strength and conditioning, the fundamentals of healing, and they're doing those things to the best ability that they can be done. I know for myself, when I first started practicing, I spent way too much time cueing athletes when doing agility and sprinting drills on mechanics and foot placement and stride length and like all of these things. And what I ended up learning is that the athlete wasn't ready for that activity. They weren't strong enough yet. And one of my favorite quotes is from Cormier et al. In 2011. In the paper, they state that a fundamental relationship exists between strength and power, that power cannot exist if there's not a foundation of strength. So what I learned from that is I dialed it back and said, we're going to spend more time strengthening. We're going to get you stronger. We're going to do objective tests to show that we have these metrics that you've developed that strength. And then once you've developed that, now we're going to start moving back into these higher level of plyometrics and agility and all that. And what I found in this is that I spent way less time cueing because they were ready for it. Their body was ready for it. So it was starting to self-organize and propel themselves, and they're able to go forward. So any younger clinician listening or an experienced clinician, if you're finding yourself constantly cueing and trying to figure out, man, why can't I get this athlete to do this? Why can't I get them to absorb more force when landing from a jump? Or why can't I get them to push off the ground harder? Well, we gotta go back a little bit and see what is their strength, what are their capabilities, and let's work on that before we get to those other things. But on the other side of this, Dan, I'm interested in, as we start to get to more higher level activities, there could be potential for greater setback because we're dealing with really high levels of force. When we look at, like, for example, doing a bridge compared to doing a sprint, the forces are much different. So in this phase, there might be potential setbacks that could happen. What is the rule of thumb if a setback was to happen, in the sense of the athletes in a particular phase, they're doing sprints, they're getting up to their threshold, they start to experience discomfort, and that discomfort kind of knocks them out for 3 to 4 days where their pain symptoms are back. What do we do with that? Do we back up a couple phases? Do we stop running and go right into strength? I'm sure there's probably more factors that are needed, but generally what would we do with that athlete?
For me, when those things happen, if it's immediate, you're doing this and like, man, I'm really sore right now. Well, then we'll stop. We'll do some soft tissue work. We might do some stretching, maybe some PNF things if it's appropriate. If it's a day later, I want to know, is it in your joint, like if it's a knee, or is it your quads and your hamstrings? I think that's a little bit different. Typically I'm okay if they wake up a little stiff and a little sore the next morning, but if they get going and moving and they're fine, onward, we're going to keep going. But if they're sore 24 hours or so after our session, then we'll obviously back off of it. We would probably, for me anyway, I would do work around the joint. So maybe do some proximal hip or core work. Maybe if it's I don't know, maybe they have a history of ankle sprains or something, we could do some balance work. We might just, again, do some soft tissue work, or maybe some long lever or longer hold isometrics to still get some work into that area. But I think it's important that we have to listen to our athletes, and they need to listen to their body. And we certainly don't want anybody, you still want to go forward, even though you have to put the brakes on for a minute. So I think it's important. You can still work around it, and then just modify the program as needed to accommodate their needs, or whatever current barrier they're having, whether it's soreness or swelling or whatever the case may be.
Yeah, absolutely. Another just beautiful answer. And it's, if it comes up, let's calm it down to load it back up again. It doesn't mean we need to abandon ship or go all the way back to square one, but it's listening to the athlete. It's looking at the programming. Did we increase the workload too much, too soon for that athlete? But looking at those variables, knowing that these things are going to happen. It's not a perfect science. There's a lot of science that goes into it, but there's a lot of art that goes into it, and being able to adapt with that.
I think it's important to say here, holy cow, this room, the light's going off. I'm sorry. There we go. I had to move my arm. There we go. Sorry. Not a lot of, anyway, sorry about that. Yeah, I just kept getting darker and darker. I was like, holy cow. So anyway, no, what I was going to say, I think an important part for this particular phase for athletes is talking them off the ledge, because a lot of times as they start to get back into these things, they get in their own head a little bit that, oh gosh, I'm never going to be right because I ran at 50% of my effort 10 times and I'm sore for 2 days. And I think a lot of times we have to say, if you can, I have the luxury of been doing it for almost 24 years or so. So I have a better crystal ball. I know what these things look like. So I have the ability to say way before we do our first sprint, hey, just so you know, you're more than likely going to be sore for a day or two because you haven't done this in several months. It's stepping, excuse me, you are stepping up your intensity, which you have not, like I said, done to this point. No different than when I tell my pitchers or my volleyball players that had shoulder surgery, and the very first time they really let it go off the mound, the very first time that volleyball player goes up for a kill and just smashes the ball. Well, I can't reproduce that clinically. You just have to do it. And there might be times where you do those things, that it's going to be sore. You might feel like shocking down the, pain down the arm or numbness or things like that. Like, we'll work it out. You just haven't been there in months, right? Yeah. So a lot of times they just want to know, like, this is any patient. This is a little old man with a knee replacement, a little old lady with a cuff repair, or a elite athlete. Am I going to be okay? Yeah. And as long as you have the ability to kind of talk them off the ledge and say, hey, this is normal. Like, you're going to have peaks and valleys as you increase your activity level and as your intensity spikes. So we just have to monitor that load and volume. Don't have too much too soon, and back off if need be. There's going to be ebbs and flows. As long as they understand there's going to be ebbs and flows, they'll be fine.
Absolutely. Quick story, and then we'll start wrapping up. I remember this older athlete I was working with, and we got her loading. She seemed to be having what was a glute tendinopathy. So we started loading it, and I forgot to educate her that we were expecting soreness, that we were trying to develop strength, and we're using an intensity that was a little bit higher because of her activity level, that I was expecting that the physical therapy program was going to create some soreness due to the muscle work that had been done. I neglected to set that precedent for her. She went home, she did the program. She called me 2 days later, and she was very upset. I thought this program was going to make me feel better. I thought I was going to be back to these activities. I'm more sore now than when I came into your office originally. And so I hopped on the phone, was talking with her, and as Dan was saying, figuring out what's the soreness. Is it joint soreness? Is it muscle soreness? Where is this located? And it was definitely muscle soreness. It was just, I failed to tell her, educate her that we do want this soreness. And then when she knew that, she was okay with it. But she definitely wished that she knew that off the bat. But Dan, you have given so much to the physical therapy field, the strength and conditioning field. I think one question I have for you is there any other projects you're working on in the background? Any more articles coming out? Any more research being done? Or what's going on in Dan's life right now?
Well, first and foremost, I'm a really busy dad. I'm coaching 3 sports, so that's a project. So right there, that's a big project. But professionally, a couple things. So we where I'm currently at, we have a sports physical therapy residency here. We just actually today got a notification that we are accredited now. Our first residence wrapping up. Our next one starts up in a couple weeks. So really trying to kind of lead that. So that's been professionally, it's been something I've been really working on pretty hard. I do teach a lot on the side. So I enjoy that a lot. I've been around as long as I have, and I'm still in the trenches treating. I have patients today. I have one when we're done here. So I mean, I'm still in it, which I think is important. You know, when I'm talking about things like these, I'm still doing it. You know, with fellow clinicians. As far as projects here, we got a couple research projects going. We're doing one. Actually, the data's done. We're writing it up now, or getting it finished writing up on the ACL RSI. It's a return to sport test after ACL reconstruction, and it's basically looks at athletes kinesiophobia and physical, like their perception of their physical readiness. What we did with this study is we had them do it about a week before their first functional test, and then they did it immediately after. So what we're looking for is to see were the athletes really at where they are, or do they have delusions of grandeur type of a thing, right? And we're also doing another one, which is the one I'm most excited about. We're doing one with the Jayhawk Performance Laboratory here in Lawrence, Kansas. We're looking at isometric mid-thigh pull. And if you look at strength conditioning literature, the peak power and peak velocity of isometric mid-thigh pull often exceeds some of the Olympic lifts. Well, in early phase rehab, specifically, like let's say we have somebody with a cartilage restoration procedure, they can't do squats for 12 weeks. Leg press, none of it, like because of we have to protect the surgery. Well, how are you going to keep a quad going for 12 weeks? Yes, we could do BFR. Yes, we could do other things, but isometric mid-thigh pull is a fantastic option in those early phases to work the quad, to start working on peak power, even when they're not feeling very powerful or even very strong. So anyway, point of the study is we're going to look and see if down the road, if we do this, if it leads to improved strength measures later in those that do that in the early phases. So I would say that's probably 2 of the bigger sports medicine ones, but we're also doing another one that we're looking at. This isn't very exciting for sports necessarily, but we're looking at patients that have total knee replacement, and they're loading, if they ever symmetrically load on both of their limbs after total knee replacement. So we're testing them pre-op, 6 weeks, 3 months, 6 months, and a year, and seeing if they ever symmetrically load, or is there always a bit of a deficit unloading their involved side. So I hope you don't regret asking the question, but you're the one that asked it, so I had to tell you what we're up to.
No,
so.
I got to be honest, it gets me fired up. Like, I'm looking forward for all these things coming out. Like, all the work that you put out has been incredible, and it's all things that we need to learn more about. It's very valuable for the field. So I'm so happy with those things, because my fear was that you're going to say that you're slowing down professionally and not putting out more papers. And it makes me really excited that you are doing that, but that you're also spending time to be a coach, because I'm sure you're crushing it as a coach and as a dad. And Dan, just thank you so much for what you've done. Thank you for coming on the podcast today and just sharing all this knowledge with us.
Hey, thanks for asking me. I know you have a laundry list of people you could have asked instead, so I'm grateful you asked me, and I hope the time here was worthwhile for you and your listeners. Thank you.
Hoping you enjoyed that episode and learned more about returning to sprinting, and are maybe hungry for some barbecue. This is a bittersweet moment for me as your host, because this is the last outro and episode that I will be doing. I recently published and launched a book called Hope Not Nope: Reclaiming Identity as a Lifelong Athlete in a Sick Healthcare System, and will be stepping away from prehab to focus on getting this message of hope to as many people as possible. It's been an absolute honor to serve as your host for the past 3 years, and I'm incredibly grateful for your time listening and supporting our work at Prehab. All right, let's cover those 3 main takeaways from the episode. Key takeaway, number 1, each location's barbecue is a bit different, and the best barbecue probably lies with an individual preference. Key takeaway, number 2, return to sprinting protocols are available. Dan has a great one that's in the International Journal of Sports Physical Therapy, but know that this is a framework that can still be and should be individualized to you or your client's goals and circumstances. Key takeaway number 3, take care of the simple things first and then add complexity after. Prehabbers, thank you for listening, and let us know what you want to learn about next. Mike, Arash, and Craig are eager to hop on the podcast and answer all of your questions. Remember to share this episode, leave a rating and review, and if you're enjoying the content, subscribe to the channel. It's been a privilege to serve you, and I hope you continue to seek out the right info at the right time to take control of your health.